Hello and welcome to part 2 of this series on nuclear medicine of the urinary tract. So in the last part we had a rather long discussion on how MAG3 perfusion scintigraphy of the kidneys is performed and what sort of images we look at and what its purpose is, namely to look for to examine the physiology of the patient's kidney in order to determine if there is obstruction present or not. Now MAG3 is probably the most commonly used tracer for that purpose today, but there is another agent which we're just going to briefly mention, and that's DTPA, which stands for diethylene triamine pentacetic acid. This is a little bit cheaper than MAG3, and it is only filtered at the glomerulus. It is not excreted into the tubules. That results in a somewhat lower extraction efficiency than MAG3, which means that the image quality is not quite as good. The signal-to-noise ratio of your images will be somewhat reduced. But they're still actually quite good, because this is intrinsically a test with quite a high signal-to-noise ratio. So many centres do still use DTPA for their imaging studies when they're looking for urinary tract obstruction. In addition, because it's only secreted at the glomerulus, we can use small amounts of DTPA injected into the patient and then followed by serial blood sampling in order to assess their absolute GFR measurement. And that's something that it's a non-imaging test which is sometimes requested by clinicians, as I briefly mentioned in the last examination, if we want an accurate assessment of the patient's GFR prior to transplantation or cisplatin-based chemotherapy. So really the pictures that we're going to see with DTPA won't be significantly different from MAG3, except possibly the image quality might not be quite as good. So what we're going to do now is we're going to go and look at some of the pathological conditions, which we might see on MAG3 and DTPA scintigraphy. So that's MAG3 and DTPA essentially will produce the same imaging appearances. So if you remember, we spoke about the most important image data set that we produced during this examination as being the later dynamic phase of the renogram, these 3-minute frames. We can see here that in this patient, if I just go over here, we've got some nice nephrograms in the first 3 minutes, and then we can see some activity accumulating in the left renal pelvis. Don't forget the left is on this side. Now sometimes only the images won't be labelled in all cases. They have actually been here. I just again had to chop the top of this off because of patient demographics, but occasionally they'll only measure they'll only mark one side, only the left, which is a bit lazy, but sometimes that does happen. But don't forget again, this is a posterior view of the patient. So the left is over here and the right is over here. It's opposite to as you might think from a conventional coronal nuclear medicine, a coronal CT scan or other imaging tests you might be used to looking at. So we can see that there's activity accumulating in the patient's renal pelvis on the left. There's a normal renal pelvis here on the right. Quite a lot of activity there, quite a lot of activity still. Is the left renal pelvis obstructed? Does the patient have PUJ obstruction? Well, no, it clears away, as you can see in the later part of the examination. So what we might expect if we were to draw one of those time activity curves would be the activity has gone up quite a lot here. It's increased because we've got a dense set of activity in the renal pelvis, but then it's cleared, and it's cleared probably after the diuretic was administered sometime around this time. So it will have cleared down at that point. So let's have a look at the time activity curve and see actually what happened. So here is the patient's time activity curve, and if I just refresh you, so the left kidney is the one with all the increased activity. So the left kidney is green, the right kidney is red. So I might just mark that in just for convenience here. So this is our left kidney. And as you can see, what's happened here is the activity in both kidneys has shot up during the early phase of the examination. But this time activity curve on the left is demonstrating a continuous high level of activity, which we might think was due to obstruction. And in fact, if we hadn't given the patient a diuretic, that activity might have hung around or persisted in the renal pelvis for some time, and it might have taken a long time for it to clear. But in order to accelerate that process, because we can only keep the patient under the camera for a limited period of time, we've given the diuretic, and you can see that that's caused a rapid decline in the curve level, and that's due to the patient having rapid clearance of the tracer. And that is, if I just go back, that's visually reflected here in the fact that this pelvis has now begun to empty. You can see it's less dense. And by the end of the examination, it's cleared reasonably well, not quite as good as the other side. And so that's our time activity curve. It's helpfully marked here, actually, the kidneys. There's our output efficiency curve. So you can see that the left kidney was lagging behind. He was clearing rather slowly. The clearance was slow, which reflects this part of the curve here. He wasn't clearing down nicely like the other kidney was. But in the end, he made it in the end. So at 30 minutes, we would expect his output efficiency to be up there in the 90s. So here's our delayed picture. The bladder has emptied nicely, and again, there's only a small amount of activity persisting. It's probably cleared even more on the delayed image. So we don't have I don't have the data there for the relative renal function, but I think we can be pretty confident that that output efficiency was well in the 90s. So no evidence of obstruction there. And this is the classic, I'm just going to clear this here. This is the classic question that you're asked in MAG3 renography. This patient's got a big renal pelvis, big pelvic calyceal system. Is it obstructed or isn't it? And here we have what's essentially a capacious or baggy collecting system, which is clearing in response to the diuretic. So this means that the patient probably doesn't require any intervention. And we also tend to note if the patient has symptoms at the time of the diuretic injection, because if they are obstructed, that's often the time at which symptoms may occur, because the diuretic will cause increased renal blood flow and will therefore cause increased passage of urine through the PC system and ureter. And if the patient has a PUJ obstruction, that is if they have a fibrotic band at their pelviureteric junction, which limits the amount of urine that can pass through, that will often cause the patient to develop symptoms shortly after the administration of the diuretic, and that's worth noting, so you can put it in your report. So let's have a look. So that's a capacious system. Now let's look at a patient who's actually genuinely physiologically obstructed. So this is our old friend, the initial images. If you remember, this is the first minute, which we looked at before. And here we can see the tracer coming down. I'm just going to change back to red, actually. Seems a good baseline color. And you can see the tracer coming down the aorta here. And it'll be going into this kidney here on the right. And then there's not much activity here in the left, so there's not much being taken up there. But later on in the first minute, you can see this left kidney beginning to become visualized. And you can see, as I was saying earlier, sometimes the technologists only mark one side, which is, unfortunate. It should be both sides marked, but unfortunately sometimes only one side is marked. So you need to be a bit careful when you're looking at your markings. It can be a bit confusing. There should be an L there for left. Again, this is a posterior view, remember? So you can see that in many ways this was a helpful picture to make, because we can see clearly the difference between the two kidneys and the difference in the early perfusion between them, which can of course be due to many things, but obstruction would be a common one. So here are our later pictures, and although you might say, well, I can see that that there's a difference here, it might not be so evident that it was in the first minute, the very early phase, that the patient had the poor perfusion. So here you can see that the activity is accumulating within this prominent pelvic calyceal system on the left over time, and really there's not an awful lot of clearance taking place. It just gets grayer and grayer and blacker, and there's not much clearing, as we have seen in the previous examples, while on the right hand side, this kidney here, although it develops a very black renal pelvis, it quickly clears down the ureter into the bladder. So this kidney on the right is having no difficulty clearing. This one on the left is just accumulating tracer, and therefore we're just getting blacker, 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 blacker all the way along. And so what we might expect is a time activity curve, which was something like this, getting more and more and more activity and failing to respond to the diuretic. No clearance when the patient is given diuretic. So let's have a look at that time activity curve, and that's exactly what we have here, of course. So unfortunately, in this particular case, the two shades of green denote the kidneys. So the let's call it the bright red, the bright green in this case is the right kidney, which is the normal kidney, and we've got tracer uptake. Bit of hesitancy here, maybe. Perhaps that's because of that prominent renal pelvis which we had there, but that's just pretty much a normal extrarenal pelvis, and you might see that. And then you can see it's begun to clear normally, quite a bit of normal clearance, and that continues after the diuretic to good final clearance at the end. But of course, on the left side, nothing of the sort is happening. You can see that there's progressive accumulation of the tracer with no response to the diuretic whatsoever, furosemide here at 15 minutes. So this is an obstructed kidney. The relative renal function is reduced on the left-hand side, and that may well be due to the patient's obstruction. Doesn't necessarily mean they've got a permanently damaged kidney. In fact, we would expect that it's just due to the obstruction. And the output efficiency here is only 52 on the left. And you can see that's manifested here. We spoke about the output efficiency before. This is a nice output efficiency here on the right side. It waits a couple of minutes before starting because, of course, this right kidney is just taking up tracer for the first couple of minutes. It's not clearing. But then after a few minutes, the right kidney starts to clears rapidly, and this going up here is a manifestation of this clearing going down here. But of course, this left kidney isn't doing anything like that. It's got very limited clearance. There is some clearance taking place because it's very rare for a kidney to be completely obstructed. If you tie off a ureter and effectively make a kidney completely obstructed, it will die very quickly. So there's almost never complete obstruction in these cases, and it's better probably to speak of high grade or low grade or no obstruction. But you can see that there's some clearance, but it's clearly not what we would expect. So this is 54% here, I think. So at 30 minutes, we can read the graph off here. So it looks about 50 to me. Perhaps I'm shortchanging it a bit. It's slightly higher, so that would fit with 52, which the computer is telling us. So that's reduced output efficiency of the left kidney. And we'll quote these numbers in our report so the urologist will be aware of them, and we can use them after treatment to see how well they've done with the pyeloplasty. So this patient has obstruction at the level of the renal pelvis here. It's usually due to a PUJ obstruction. Of course, it could be due to tumour or a stone, but we would hope that those other causes would be excluded first before we evaluated the patient for a PUJ. So usually the patient these days, the patient will have had a CT urogram or some sort of CT, and you'll be able to see if there's an anatomical lesion there. Or they might just have had an ultrasound and have classic appearances, in which case it's fine to go ahead. But it also depends on the age of the patient. So a young patient with no history of renal stones, they might just have and it's found on an ultrasound, they might just go straight for an examination like this. But an older patient, a smoker in their 60s, we'd probably want to do a CT urogram first to make sure they hadn't got a transitional cell carcinoma in the renal pelvis. But in any case, so it has to be integrated with the other imaging the patient has, and that's the strength of nuclear medicine, is integrating the physiological information we get from these studies with the very good anatomical data we get from CTs and MRIs and ultrasound. So the patient went on then, and they had a pyeloplasty. And here we can see the MAG3, which was performed after the pyeloplasty, which is often done to see how well the patient has done. And you can see here that there's, again, dense activity accumulating in the pelvic hail seal system, but that's nicely cleared later on in the examination. So that's much better than before. And I'm just going to show you the pre and the post together. So that's the post pyeloplasty. and here's the pre-pyeloplasty image again. So you can see the difference. So that's before, and that's after. So a considerable improvement. And we have a time activity curve of after. So if you remember, this left kidney was showing a progressive accumulation of tracer without any clearance, but now it's clearing nicely after the diuretic has been given. It's just shooting straight down here. And I'm going to take this opportunity just to mention a measurement which we can use, which we can take, which is sometimes useful in the interpretation of these studies, because this is a fairly easy one, but unfortunately sometimes they can be equivocal. So there is a measurement which we can make and quote in our reports, which is called the clearance half time. And that's effectively a measurement of the slope of the curve, of the renogram clearance curve. So how do we calculate that? Well, we usually take it from the point at which the patient started to respond to the diuretic. So the diuretic was given here, and the patient started to respond straight away. Now, I'm afraid these are not going to be very good pictures, but what we do is we want to draw some sort of a line here. So what have we got here? 50, 60, 70, 80, 90, 100. So that's 50, 60, 70, 80. So perhaps that's going to be 82% of the activity at this point. The maximum, the 100%, is the peak of the curve there. That's what it's taken to be. Because on this particular graph, instead of absolute counts, they're using percentages of the maximum count, and that's a way you can scale the graph. So you make best use of the available space by putting the highest point of the graph at the top. So if we say that 82% of the activity was seen in the left kidney at the point of diuretic response, which was immediately after diuretic was given. So we could say the patient started to clear just here. And then what we do is we count 10 minutes further forward. So that's 15 minutes. So at 25 minutes here, we can then read off the activity here. And that's going to be 10, 20, so that's 15. So with a normal clearance half time, the tracer should clear fairly quickly. And what should happen is if you take 0 point from when the first diuretic response occurs, the clearance half time is the time taken for the activity to go down to half of the level at this particular point. So we take the activity level at the first diuretic response, which is 82% here, and then we need to find when 41% occurred. 41% would have occurred somewhere around here at this point. So how many minutes is that? There, that's let's say 19 minutes, so that's 4 minutes. So the clearance half time was only 4 minutes. So if the clearance half time is less than 10 minutes, that's normal. If the clearance half time is greater than 20 minutes, that's abnormal, indicates obstruction. And if the clearance half time is between 10 and 20, it's somewhat equivocal. So you can see, but essentially this is just a measure of the slope of this excretion phase of the examination. And here it's pretty much a vertical line. So this clearance is extremely rapid. So this is exactly what you would hope to get. Very rapid clearance through the kidney, indicating there's a wide bore in the PUJ after the surgery. So a very successful surgery here. We can also see that the output efficiency is back to normal, 95, and you can see the curve, despite some initial hesitancy, it's got up to pretty much the same level as the normal right kidney. So this is really what our baggy pelvis looked like in the first example we saw. And our relative renal function has it improved? Let's go back and have a look. 28% before. It's now up to 39, so it's certainly improved by 10%, so it's improved a bit. Perhaps it will improve more. There may be some underlying renal damage, but it's certainly an improvement, and hopefully the patient won't deteriorate. Remember, 55-45 is the normal limit of a split, so it's not that far off that. So this is a patient who's had a PUJ obstruction and has had it treated with pyeloplasty, and I've seen the dynamic phase and the time activity curves before and after the treatment. So I think we're going to leave it at that at this point, and we'll look at some other of the slightly more quirky renogram curves in the next episode. So I hope you enjoyed this and found it to be useful, and I hope to see you in part 3. Thanks very much.